The way that the current immunotherapies are working is that they're called checkpoint inhibitors. So it turns out that tumor cells send out these checkpoints, essentially signals that can help to block the efficacy of your own immune system. And the way the inhibitors work, roughly, are to come in and stop those signals and allow the immune cells that are sitting there in that tumor microenvironment to do their job.
Melanoma was always the poster child for immunotherapy in cancer. And it had several reasons, and also the body defense system in melanoma patients is very active, and the cells also could be taken out of in surgery, out of the body, and they could be maintained in the laboratory, so one could study them and one could study the interactions of the tumor cells. Until about, I would say, 7 or 8 years ago, all the large clinical trials in immune therapy did not work. They were completely failing. And then there was again, from some mouse experimental melanoma studies, a new class of drugs came up. And they suddenly started to work not only in mice, but then also in patients. And the first drugs have been approved about 5 years ago. And these are the drugs that Jimmy Carter got treated with. But they still have some problems because they don't work in all of the patients, but only in maybe 1/5 of the patients. And there's also 1/5 of the patients who have really severe toxicities that they have to stop the treatment. So what is the challenge is now to identify those patients who will really benefit from these new therapies and then avoid treating those patients who would be hurt. So we need to not just take care of the 20 or 30%, and that's roughly the percentage of patients who are getting almost cured. We are not sure yet, but we think so. But we need to up this, and that is a big challenge. We are not there yet.